Good evening, everybody. Welcome to the second series of the Chronicles of Wound Site Investigation webinars. This evening, we are very glad to have presenting for us Dr. Afsaneh Alavi and Dr. Bob Diegelman on the topic of Pyoderma. Please note, if you have any questions throughout this evening's presentation, utilize the Q&A box, not the chat box, so that we can address as many questions as possible at the end of the webinar. And as a reminder, this webinar is being recorded. I am Dr. Kath Bogey. I'm professor at the Case Western Reserve University, research career scientist at the Cleveland VA, and I am the chair of the Education Committee, and I will pass you over to Rummana Aslam.
Good evening, everyone. It's great to see lots of friends and others. I'm going to be the moderator. I'll monitor the Q&A. As Kat said, please utilize that. I am at Yale School of Medicine. I'm the chief of physical medicine and rehab and the medical director of wounds. So I'll pass it on to Bob and Afsaneh to take over and start.
Good evening. I'm Bob Diegelman. I'm an emeritus professor of biochemistry and molecular biology at the Virginia Commonwealth University School of Medicine. I just retired last year after 50 years of active research, mostly in the area of collagen metabolism, wound healing, tissue injury and repair, and combat casualty care. And I'll be making some comments as we go along about some of the basic science elements of what we're seeing in this treatment.
Hello, and I am Afsaneh Alavi. I'm a dermatologist at Mayo Clinic in Rochester, Minnesota, with special interest in inflammatory wounds. And here I have a pleasure of presenting with Dr. Diegelman on Pyoderma gangrenosum. And I'm going to start with a case that I'm sure many of you have seen similar cases. A 29-year-old female with history of inflammatory arthritis and leg ulcer that started as a pustule and then progressed, hospitalized in hometown for 1 week. The wound was debrided and get worse, dramatically get larger, and the wound is extremely painful. 4 weeks later, wound started slowly epithelializing after control of underlying inflammatory arthritis and treatment with absorptive silver, continued exudate, but the amount of exudate were less. Then patient received collagen dressing and in addition, compression therapy. 3 weeks later, wound slowly from the border got immigrated and got the wound become smaller. And this is 1 week after using collagen dressing, the collagen application, and here healed with an atrophic scar 2 months after. Pyoderma gangrenosum ulcers are not common, are rare and a neutrophilic condition that present as ulcers that are violaceous, particularly at the border, undermined border, and purplish border. These are characteristic of these wounds. They start with a pustule and rapidly grow. They're extremely painful, are surrounded by erythema in most cases, and when they heal, they leave scar.
So this is a typical histological feature shown here, where the problem is there's so much neutrophils and T cells in there, and the neutrophils are filled with granules that contain a lot of destructive enzymes, matrix metalloproteinases, that break down the matrix. And that's some of the rationale of why collagen dressings are useful, because we call that a substrate decoy. So instead of the neutrophils proteases tearing up the host tissue, they will go after the collagen in the dressing, and that's kind of a distraction of the enzymes. So this is mainly, it's not an infectious problem, it's more of an immune system dysfunction with excessive response of neutrophils. Now, we know a lot about the neutrophils by studying them in pressure ulcers, for example, and some of that information should be translatable to the treatment of PG. So we do a diagnosis of cultures and stains. They're necessary to confirm that it's a diagnosis of exclusion, that it's not an infectious problem. It's more of an altered immune response. And the treatments are corticosteroids, cyclosporin against the T cells, and anti-tumor necrosis factor alpha. And there's the name of the drug that is used, infliximab. The neutrophils are filled with many, many granules, and they're listed here as some of the materials that are in these granules. I'll just draw your attention to a few of the key elements. On the left there, myeloperoxidase is very important because that helps to generate the hypochloric acid that is used, and also hydrogen peroxide that kills the bacteria that are engulfed by the neutrophils. The other neutrophil elastase is also very important because it can destroy growth factors. We've reported on this in our journal, Wound Repair and Regeneration, where that enzyme neutrophil elastase can break down PDGF and TGF beta. In the next area, the specific granules, the main one there is collagenase, and that's the MMP matrix metalloproteinase that breaks down the extracellular matrix. As the matrix is first hit by the collagenase, then the next enzyme is the gelatinase in the green. And the gelatinase further breaks down the collagen into small peptides. And in the secretory granules, there's a whole host of mediators and cell determinants that are present. Next slide. This demonstrates the ability of the neutrophils and macrophages to produce reactive oxygen, ROS, and that's how they kill bacteria. So in the membrane of the neutrophil, once a bacterium is engulfed, the NAPDH system, oxidase complex, begins to generate reactive oxygen species, O2. That spontaneously goes into hydrogen peroxide, H2O2, which then the myeloperoxidase converts that to the hypochlorite. So the combination of hypochloric acid and hydrogen peroxide is what is needed to kill the bacteria. In the right panel, there's a dye present that can pick up the presence of reactive oxygen species. So in the first panel, you can see once the foreign material is ingested, then goes down and eventually engulfs it with all of the reactive oxygen species and hypochloric chloride that kills the bacteria. Next slide. Topical application of a TNF alpha neutralizing antibody has been shown to improve the healing in therapy-resistant chronic leg ulcers. So in the left panel, it's been applied, this infliximab has been applied topically to a number of patients. And as you see, with progressive time, the wound goes on to heal. So TNF alpha is a very potent inflammatory mediator. And by neutralizing that with the specific drug, you can control the inflammation that's present. So this wound is just out of control with too many neutrophils and too many proteases and inflammatory mediators. In a similar panel on the right, another case is shown that after 3 weeks of treatment with this drug that neutralizes TNF alpha, that the improvement can take place. Next slide. We have found that doxycycline, which is a very common antibiotic, also has a totally different activity, and that is it is a protease inhibitor. So on the left side, it shows how doxycycline can knock down the matrix metalloproteinases. It can also block the TACE, which is a tumor TNF alpha converting enzyme. And it also knocks down some of the other mediators that are causing all of this inflammation. So on the right side, it shows the effect of doxycycline in the protease activity. So doxycycline has the ability not only to bind to and inhibit the matrix metalloproteinases, but it also prevents the expression of that enzyme. And in the red, it shows how increasing dosages of doxycycline can reduce the protease activity. In the green is tetracycline, has a similar activity, but not as potent as the doxycycline. And in the final purple, it shows a broad spectrum matrix metalloproteinase inhibitor can do the same thing. So the point here is that the active problem with these PG is there's so much proteolytic activity going on in matrix destruction because of the amazing amount of neutrophils that are there. In the bottom panel, it shows how doxycycline can also knock down the TNF alpha with the very increasing concentrations. And that's the TACE enzyme that's decreased. So in the top panel, it's some work that we did with giving systemic doxycycline to pressure ulcer patients. Now, we've learned a lot about the activity of doxycycline by studying pressure ulcers because they are also an inflammatory condition that are driven by many, many neutrophils, too many neutrophils. So on the left side there, you can see the vessel, all of the endothelial cells are rounded up, they're dysfunctional, they can't transport oxygen and nutrients into the matrix. And the enzymes released by all those neutrophils that are there and showed in panel B, it's just filled with broken down matrix material. Now, after 2 weeks of treatment hold on a second. Sorry about that. After 2 weeks of treatment with 20 milligrams of doxycycline, you can see how in C, the endothelial cells have gone back to normal. The matrix is starting to fill in, and then also in D, you can see that. Now we use 20 milligrams of doxycycline because you want to use it for a long period of time. And if you put it up to the normal dosage of 200 milligrams per day, twice, that can allow opportunistic infections to take place. So 20 milligrams is sufficient enough to knock down the expression and the activity of the matrix metalloproteinase. Now you can get that produced in one of these pharmacies that can combine into like a pediatric syrup at a dose of 20 milligrams per tablespoon or teaspoon. The bottom panel in this study here, we used topical doxycycline that was formulated at the level of 1% in carboxymethyl cellulose. And once again, you can get these produced in a pharmacy that can combine drugs. So topical doxycycline is shown here in the purple, and all these on the left side. Once topical doxycycline was put on there, all these are all pressure ulcers diabetic foot ulcers. They all began to heal. Now, diabetic foot ulcers are also filled with a lot of inflammatory mediators and neutrophils. And on the right side, it shows in the green where the ulcer stayed open without treatment. And then in the next line, the orange, there was a crossover where topical doxycycline was applied, and then it started to heal very rapidly, and likewise in the blue. Back to you.
Yes, and now some clinical or history of PG. The story of PG goes back to 1908 when a French dermatologist, Dr. Brock, noticed that there are wounds that they had very irregular shape, and he called these wounds geometric phageedema, a French name for these ulcers. But the name PG, Pyoderma gangrenosum, was coined at Mayo Clinic in 1930 by 3 dermatologists who noticed patients with Crohn and ulcerative colitis. They come with these active ulcers and they get worse after a trauma. They describe these ulcers, they describe the pathergy, they describe the association of Crohn and ulcerative colitis with these conditions so well in only 5 cases that they presented that terminology of pyoderma gangrenosum stayed with us since when, even though it was a misnomer. They thought this is an infectious condition, And actually, these wounds, not only they are not pyoderma, they are not infectious, and they are not gangrene, they are not gangrenosome, but this name was coined in 1930 after their paper, and they introduced, and they had a nice description of that. Pyoderma gangrenosome is an inflammatory ulcer. The active border that you see around this area and the color that you see, it's mainly from, I see, okay. It's mainly from the deep neutrophil that we see here. And this, we see an erythematous halo around it. And the typical PG is easy to diagnose, but it's one of the disease that very often is overdiagnosed. Many ulcers that people don't know what is the cause of it, they call it PG. We discuss it later, that how this causes challenges. Pyoderma gangrenosome has multiple variants, morphological variants. The most common one that we see in wound clinic very often is the ulcerative form. And it's very more common on lower extremities. It happened after a trauma that we call pathergy. The less common variants are pustular PG that happen in patients with inflammatory bowel disease as pustules that are on a red base. Bullous PG, very often on upper extremity and face, very rare condition, but it's an alarming sign of an underlying malignancy, and in many cases, leukemia. And vegetative form of PG, that or superficial granulomatous PG that happen in people without any underlying disease. Most of the time could be just a solitary one lesion, and this is vegetative form. We have two other form of PG that you have heard about it, post-surgical PG and periostomy PG. But both actually are variants of ulcerative PG that happen because of pathergy. In a person that is genetically prone, a trauma triggers keratinocytes to release interleukin-36, interleukin-8, and trigger a cascade of inflammation. And you heard from Dr. Diegelman the role of neutrophil that create this inflammatory ulcer. Bob, any comment here on the pathogenesis of PG and pathergy? Dr. Diegelman, okay, then I move on.
Well, IL-8 is a very important mediator. It's given off by neutrophils and also by T cells. And that's a potent chemokine signal that brings in more and more neutrophils. So it's like in a vicious cycle where these signals are given off and they keep bringing in more and more inflammatory neutrophils. And you see the role of the T cells there. That's why cyclosporin is being used.
Yeah. And thank you so much. And here, yes, IL-36, IL-8, PMN, and T cells that are all around the hair follicle, they are collected. As we said here, PMN in the dermis cause the deep discoloration that we see at the border, an active, angry border of these wounds. And in the periphery, we have usually lymphocyte. That's why it's important that how we do the biopsy, when we do a biopsy to diagnose PG, it should be from active border and contain a little bit of border and a little bit of ulcer. If we come here and do the biopsy in middle of ulcer, we don't see what help us for diagnosis of PG. And I have to say, after 100 years of after diagnosis of this type of ulcer, these wounds are still very challenging and to diagnose and challenging to manage. And most of the time when we do biopsy, actually, we want to rule out other causes that mimic PG more than make the diagnosis. And what happens that when we have inflammation, then we have central necrosis and detachment of epidermis. And actually, when we have healing, the first sign of healing also is attachment of these borders and the slow healing that we see in these ulcers. This is a case that we saw in March after receiving treatment April and healed with a scar. and remained healed. Well, one of the important aspects of this challenging wound that is of interest of not only wound healer, but also gastroenterologists, dermatologists, and rheumatologists is up to 75% of PG ulcer are associated with an underlying disease. The most common one is inflammatory bowel disease. The risk of having PG in a person who has inflammatory bowel disease is 29 times higher than a person that doesn't. And usually IBD and PG happens in people that are younger. Many of these patients are a smoker and they have high BMI. While association of malignancy and PG is patients that have bullous PG, they have atypical presentation, and when we do blood work, lots of them, they have abnormal immunoglobulin or gammopathy. Inflammatory arthritis is about 15 to 20% of patients with PG. They have rheumatoid arthritis and other type of inflammatory arthritis. There are 3 types of criteria how to diagnose PGs, and some they gave more weight to do biopsy, some less, but just to remember that this Paracelsus is one of the ones that have more supported in the literature, and it's basically a rapidly progressive ulcer, painful, and has no other causes, exclusion of other causes. I just put a couple of cases to just be aware of this. This patient was referred to the PG clinic. Patient was on many biologic, was on IVIG, was on a steroid, and had a biopsy that actually 2 biopsy that showed neutrophil, but patient was not healing. And when it wasn't healing, then the drug was increased without repeating, doing a culture. It's important that when we do biopsy, half of the tissue go for culture. And all we did when patient was referred, we did another biopsy, and this time sent half of it for culture, and it shows that it was actually sporotrichosis. And when we went back to the biopsy of previous biopsy to see what it wasn't seen, actually sporotrichosis was present, but was in a very small amount, and it's hard to diagnose if we don't order the culture. And this patient with antifungal treatment had a great response. Another patient had a biopsy, and then at the site of biopsy developed this ulcer that actually has an active border. But again, here the tissue was not sent for culture. And actually this was a case of blastomycosis. And here you see that with a special staining, we see the fungus, which is a type of deep fungal infection. Then it is important to rule out other diagnoses before we put the diagnosis of PG. And when you diagnose PG, then we have 2 treatments, like a tandem. Both of them are needed. Proper wound care, optimizing wound care, but at the same time, stop the inflammatory process. We usually start with a rapid acting agent to stop the immediate pain and give patients some relief, and a long-term immunosuppression. If the lesion is small, less than 5% of body involved, or periostomy PG, or a small area, it can be managed with topical therapy. It could be potent topical steroid, intralesional steroid, calcineurin inhibitor, that is actually topical cyclosporin, topical dapsone, and topical JAK inhibitors. If it is, and here, if we use topical therapy, most of the time we target the active border around it, not the center of the ulcer, because most of the T cells are around in the periphery. And then systemic therapy, as you heard from Dr. Diegelman, steroid, cyclosporin, and anti-TNF, and other biologics, lots of other biologics, JAK inhibitor can be used. For wound care, it's important, a gentle cleansing, avoid with trauma, going more towards autolytic debridement and avoid sharp debridement, because sharp debridement make the wound bigger, using anti-inflammatory dressing and compression therapy. Sometimes, particularly more in non-wound clinics, they think that compression therapy is only for venous disease, while when we have a leg ulcer with edema, control of edema help healing of this ulcer. Here from this paper, if we have a mild disease, low dose prednisone, topical steroid, and if it doesn't heal, then consider biologics, and then going to maintenance therapy. If it's a severe disease from the beginning, rapid acting like cyclosporine, prednisone, and then go to biologic. If wound at the beginning, wound better to be seen more frequently, and when it gets better, then we go to maintenance. Periostomy PG are 15% of pyoderma gangrenosome, most common in Crohn, more than ulcerative colitis. In average, happens months after ostomy, but it's a pathogen. It depends on ostomy output, and if it's not sealed well, then the skin become irritated, and we see this in a person that is predisposed. And topical steroid, intralesional steroid, and sometimes systemic steroid is the treatment, but the best treatment is surgical closure of ostomy if it's possible. Post-surgical PG is another type of PG, which is a nightmare for surgeons, because you do a surgery and then usually an average 1 to 2 weeks post-surgery, the wound dehisced and open, and it's very difficult to diagnose from wound infection because the symptoms are very similar. And the risk of, if somebody had previously PG or a PG that is under control, the risk of having PG at the site of surgery is 15%. But if a person has active PG, this risk goes higher. And the most common type of surgery associated with PG is breast surgery, particularly breast reduction. And pre-treatment with one of these, either cyclosporine or prednisone, help to control that active inflammation. This is a patient that had PG post-surgery from the paper that you see here. And just a shortest story of periostomy PG. This patient had PG and was sent by surgery because they wanted to close the ostomy, but because of PG, they were afraid of pathogen and wanted to be managed first. And what we have to seal the ostomy. That's important, in addition to using topical steroid. And sometimes we try to protect that area. This is one of the tricks that we use very often in the clinic, window hydrocolloid or any type of dressing that we can cover the area that is exposed to the fluid, in addition to sealing of the ostomy. With here, I go to the summary. Then diagnose the PG is mainly clinical. We may not, ideally we like to see neutrophil in the pathology, as you heard from Dr. Diegelman, but it's not impartially treated, and in many cases you may not see it, and the diagnosis is clinically. You have to rule out other causes. You have to do workup for underlying disease, inflammatory bowel disease, rheumatoid arthritis, underlying malignancy, and it's a combination of medical management to control the inflammation and also proper wound care and avoidance of pathogens. With this, we are happy to answer the questions.
Thank you so much, Dr. Alavi and Dr. Diegelman. This was very information. I learned some very key elements also. I will encourage everybody to put questions in the chat, please. We have one question, and the question is, can you explain the application of, or how would you do application of infliximab?
I think I can comment on that this was a study that was done more in research base, in clinical use, we usually give infliximab as a systemic therapy. Its other names are Remicade, and many of these patients, if they have IBD, may be already on. And you do the screening, there is no contraindication, and then it's an infusion that is prescribed per weight.
Okay. I would like to know a little bit about, you mentioned a whole list of topicals. In your practice, what are the usual like first go-to topicals that you start with?
You know, steroids, despite all adverse event and fear of a steroid, still are first-line therapy. Then topical steroids are first line of therapy when we go with topical therapy. And we usually, it's important that you be applied to the border. It's important to use stronger steroid. Something like hydrocortisone doesn't work. You have to go with like clobetasol, triamcinolone, this type. And ointment-based is better than cream-based. And why ointment is better than cream? First of all, ointment is stronger than cream. Second, ointment is based on oil and you don't need preservative. But when you have cream, you need lots of preservative to avoid and to sustain the cream. Then this preservative, all of them are potential allergens. Then for wounds that is open surface, it's better that you go with ointment-based rather than cream-based.
That's a very good point, because clinically I have been just using ointments based on my observation that they always work better. So now I know the explanation.
Just I add the second line would be calcineurin inhibitors, which is like topical cyclosporine. It's theoretically topical cyclosporine. They will be second, like brand name would be Protopic or anything.
If the patient is going to have a surgical procedure, and I've been asked this question, or actually we should advise our patients when we diagnose them with PG, that in the future, if they get anything like tattoos or body rings or a surgery, is there anything we can do to prevent or minimize the risk of development of PG?
This is a great question, because lots of our patients, they don't know. And that's what is the risk comes. I had a young female with Crohn, that the Crohn was relatively under control, but went for nipple piercing and came back with a large ulcer on breast. And she has never been told that because of having Crohn, she should be careful about any elective surgery. Then it's important that we counsel patients that have potential. It's not a very common disease. At least they know that they are taking the risk. And in particular, if patient had a history of PG at some point, then the risk is higher, is 15%. And if has an active PG that is not under control and is going to have an elective surgery, like removing a mole that is not cancer, or having a knee replacement that can wait till PG be controlled, then it's better that they wait to control it. If there is an urgent surgery or there is a surgery that cannot wait, we can give systemic steroid prior to surgery, a week prior to surgery, and a week after surgery, or more if needed, like 2 or 3 weeks after surgery to manage the inflammation.
Do you know if anyone has tried using doxycycline either systemically or topically for PG?
Actually, I want to ask, I like to get your comment more about the topical that you said, you mentioned. We give doxycycline for if there is concern about infection and inflammation, because it's a great antibiotic, but only doxycycline for management of PG, purely doxycycline, I haven't given. And usually I give it when I need an antibacterial effect plus anti-inflammatory effect. I have to say that topical doxycycline is available in the market as a foam and lotion, but I'm sure much more expensive than what you mentioned. And that would be cheaper if be compounded.
Yeah, I checked with the compounding pharmacies locally here, and they said they could compound it at 20 milligrams per teaspoon using a pediatric syrup, for example. I think Greg Schultz is on there. He had some work with the topical doxycycline was done in his lab. Greg, you want to make any comments? Greg Schultz, are you there?
I did see his name, and there's another question actually.
Okay.
So I don't know if Greg is showing up. So Greg, please feel free to jump in when you're ready. In the meantime, there's a question, and the question is for Bob. Is there any more progress with commercialization of topical doxycycline? This looked like it was moving forward about 10 years ago and then disappeared. And again, another comment to that question is that I think the dose for anti-inflammatory doxy is lower than oral use, which I think we touched upon. So is there any progress with commercialization? Anybody knows?
You mentioned that it is available as a foam, but it's very expensive. And but it can be formulated very easily with these compound pharmacies. And the dose of doxycycline is lower at 20 milligrams versus 200 milligrams, because as I mentioned, if you give a patient 200 milligrams twice a day for a long period of time, then you have the problem of opportunistic infections. And 20 is all you need to knock it out. This is kind of based on the periodontal literature, where they used a thing called Periostat, which is 20 milligrams of doxycycline twice a day. And that is enough to knock down the neutrophil activity in the MMP8 that the neutrophils put out.
Do you, Bob, do you think that if it is a lot of inflammation, like Afsaneh said, is it better to go with a higher dose of doxy for like a week or so and then decrease it, or it doesn't
Yes,
break that because of the mechanism?
People say they use 200 milligrams for 2 weeks and then knock it down to 20 milligrams for a longer period of time. So the first 2 weeks at the normal dosage, that would help to control the bacterial infection as well as knocking out. But then after 2 weeks, you should go back down to 20 milligrams twice a day.
Yeah.
I don't think that's been published. I just heard that from several people that have tried it. And this is once again in pressure ulcers,
Right.
not PG.
Yeah, in clinic, we like, I think this needs a study. Doxycycline is an amazing drug and needs a formal study, particularly when we talk about PG. We have to have a study on PG that we don't have. And sometimes using lower drug dose, and I wish Dr. Schultz could comment on it too, is increase the risk of bacterial resistance. Then that's different things that we have to just consider when putting the plan for treatment. But absolutely, we need a formal study to see what is the effect on the PG ulcers.
Anything besides the anti-inflammatory to control the pain? Sometimes that is the major complaint. And
absolutely, I think we have a tendency to undertreat pain, and despite that, there are so many opioid crises and other things, and that's why our hands are tied. But the patient have extremely painful ulcer, and they need pain management, either topical pain management and dressing that contain pain control, or going with systemic pain management. But I have to say that many of us undertreat these patients for pain.
thank you. There is another question, And the question, I will read it. Patient in wound care center developed abscess to PG wound. The doctor ended up opening up the abscess after admission to hospital, had IV steroids, PG improved. They did use wound vac on the wound. Wound is clean but stalled. Do you think the vac is causing more damage than good? That's an excellent question.
I think that's an excellent question. And there is no, we know that we want to be gentle with this wound and avoid trauma. And I have seen patients that when they put vac, they may develop pathogen around the area of adhesion of vac. But it depends on the stage of the wound. I don't say it's 100% contraindicated. It's case by case, because many wounds, PG wounds, they have an inflammatory stage and then they go to a non-inflammatory stage that they become a chronic wound. And sometimes they come to me, I say it's not PG, but actually one day they may have been PG because then because of infection, other things, they turn to a chronic wound. When they are a chronic wound, that they are non-inflammatory, then VAC might be indicated and be a good choice. But at the stage that is inflammatory, has that active border, we want to avoid any trauma that is possible. Then it's not a white and black. It depends on the wound at that stage. If it's active border pathogen, we should avoid, but otherwise could have indication.
Hopefully that answers the question, but a very great answer is to really see what the wound is doing, and the characteristic of the wound is important. We still have time for more discussion. There are no more questions.
Looks like there's no more questions, and Greg is keeping quiet and doesn't want to join the chat. So thank you. Thank you all for your presentation. It was really interesting, and I learned a lot because I'm not a clinician, and this is something I hope I never see. And to our audience, thank you for attending the Chronicles of Wound Investigation Series, brought to you by the Wound Healing Society Education Committee and Wound Healing U. As a reminder, the recording will be available in your member-only account on the Wound Healing U in the next few weeks. And now we ask that you also complete these few brief questions help us to continue to provide content that is of interest to Wound Healing Society members.